Hello, my name is Vlad, and today I have my 6th birthday in Odyssey. Literally 6 years ago, I joined the vocabulary team, but I'm not only a vocabulary guy, I am also a medical oncologist by my background, and that's the reason why you can see this title on this slide. Okay, so as a medical oncologist, we still have, as a majority of medical oncologists, I still utilize in my real practice conventional chemo to treat patients with different type of solid tumors. And the most dangerous and serious type of adverse events associated with such treatment is a hematological toxicity. I want to focus your attention on a particular example of such toxicity, the thrombocytopenia. This is a condition when the number of platelets in our blood reduced due to the action of chemotherapeutic agent. And after that, our body, can you move back, cannot prevent us from bleeding. All of this type of adverse events may lead to complete treatment discontinuation, dose recalculation and reduction, or cycle postponing that for sure may compromise the outcomes. So what are our management strategies in this case? There is a gold standard, and the gold standard is just to treat consequences, just to administer platelet concentrate and transfuse them, and also change and alternate the anti-cancer treatment. However, there is an alternative, or there is a potential alternative. Historically, medical oncologists used to treat patients with thrombocytopenia with glucocorticosteroids in order to facilitate the platelet count's recovery. However, this approach was shown not to be beneficial in this population or even be harmful. Outside the oncology domain, there is a quite new drug class, thromboplastin receptor agonists, that is used for pretty similar indications, thrombocytopenic events not related to the chemotherapy. So I decided to look at the most recently published guidelines, like NCCN guidelines or International Society of Thrombosis and Hematastasis, and also looked at the published articles within the UpToDate platform, and I was not able to find any direct recommendation to define the niche and role of TPO-RAs in such clinical scenario. What is also important, we know almost nothing about the safety profile of these agents, especially in case of severe adverse reactions like thromboembolic events. And the other point to be highlighted is that we have no understanding on the impact of TPO-RA's administration of number of platelet transfusions administered for such patients. All of the above helps me to formalize the primary question of the study I want to ask. So how many patients in reality diagnosed with chemotherapy-induced thrombopenia are actually exposed from drugs within the TPO-RA class, irrespective of the platelet transfusion state, during the first year of their active systemic therapy? I do believe that it will be quite a conventional characterization study with several targets, like chemotherapy-induced thrombocytopenia incidence, stratified by solid cancer type, as well as exposure to particular chemotherapeutic agent class. The outcomes will belong to two domains: procedure occurrence with platelet transfusions and drug domain with any kind of drug within the TPO-RA class, and the time at risk will be defined by the first year of active systemic anti-cancer therapy. So that's basically it. If you have interest in this particular matter, please contact me at korsik@odyssey.org, and let's empower each other with knowledge to protect lives of our patients. Thanks a lot.